It is good to be with you. So what I'm going to talk to you about are going to be blood-borne pathogens. These are some of the reasons why you're probably here today, and as you can see those, some agencies are requiring that you attend a blood-borne pathogen. The greater scheme of things, when you shake all this out, it's really good information for everybody to know, bottom line. So that's what we're going to be covering today. 29 CFR 1910-1030 doesn't mean anything to you. It's part of the Federal Register, but this is what has driven all of the blood-borne pathogen focus. It is federal law. And initially, just to give you a Reader's Digest of this, when this law first came out, as it was being written, the primary focus was to protect the patient. And the thought was, and you could tell nobody had any idea about infectious disease that wrote this as they were starting, was that we, healthcare professionals, were going to give our patients diseases. Well, they had it backwards. The patient was more likely to give us a disease than we ever were to give them a disease. And so when they were putting this together and then they started getting some medical consult in this, there was a whole change of mindset. Interestingly, at the time, I was also a volunteer fireman out at Lebanon. I spent over 14 years out at Lebanon. And the interesting part of it, I was at a conference, OSHA conference in Atlanta, Georgia, and the law was written such initially in the preliminary before it actually became official that this was only going to apply to people who did this professionally. And that term drives me crazy because just because you're a volunteer doesn't mean you're not professional, but that's a pet peeve of mine. Anyway, that if you were full-time, you got a salary. And so I raised my hand and said, wait a minute, I got a question. So you're telling me blood is smart enough to know that if I'm on duty with Durham County Emergency Medical Service, blood might infect me. But at night, I respond to a call, and I am a Lebanon volunteer fireman, that blood's going to look and say, well, you're not getting paid to do this tonight, so we're not going to infect you. I think I just stood there and he said, well, of course not. I said, my point exactly. Blood cannot differentiate whether you're getting a salary or not. And they said, this is going to have to apply to everybody who comes into contact with blood or body fluids. Well, duh. I mean, not rocket science, but my gosh, that's just kind of common sense. So this law ended up evolving into what we now know is 29 CFR 1910-1030. Now, if I had $1 for every time I've said that, I probably would not be with you today. I'd probably be thrown on some Hawaiian beach somewhere where it's warm again like it was this past week. All right, we're going to talk about infectious disease. I'm going to go over about 4 terms, and some of these are going to be, you're going to look at them and go, anybody ought to know that. Well, yeah. So much of medicine, unfortunately, a lot of people want to look down their proverbial nose as if you were only as smart as I am, you would know these things. Listen, a lot of this is just very much common sense. This is a key element for us to understand this morning. It's anything. We're primarily going to talk about bacteria and virus today. There are fungi, there are parasites, but we're not going to be talking about all these things. But our primary focus is going to be on any organism. And we're talking about organisms here, bacteria, virus for the most part. Communicable. Now this is important to understand. If something is communicable, you can see it spread from person to person. If I've got a cold, can I give it to you? Yes. If I have the flu, can I give it to you? If I've got HIV, can I give it to you? Possibly, but casual contact is not going to allow that. You can just be in a crowd and have a cold and give the cold to somebody or the flu to somebody. So if it's communicable, it can move from person to person. If it is non-communicable, obviously you cannot get it from just casual contact. Blood-borne pathogen. You see what this is? It's anything present in the blood. It can be in the organs, it can be in other things as well. But generally, we're talking about blood-borne pathogens. It's in the blood. When we talk about tuberculosis, we're going to be talking about an airborne. It is a bacteria. With blood, if we come into contact with blood or body fluids, there is potential for us to contract it. And I've got some other information we'll talk about with that in a few minutes. An antigen. Now you may think, holy cow, did I come for a biology and chemistry lesson today? No, I know you didn't. But just a very clear understanding of this is that anytime there is something abnormal in the bloodstream. Let me give you an example. In a sexual relationship, the initial times that there is intercourse with a man and a woman, the woman her body deems the sperm as a foreign body. Her immune system responds to that and develops antigens. So over time, it's no longer considered like in a marriage relationship. It is no longer considered an antigen. Her body adapts to that. But that's an example of how a foreign substance is deemed by the immune system. And that's a classic of how I've used through the years to help people understand that. An antibody, well, you can see what the antibody is. It's a protein, it's just a term we use, by the body to help develop immunity or fight off an infection. If you get stuck with a dirty needle, not even HIV or Hep B or Hep C infection, just a dirty needle, a dirty nail. You step on a dirty nail and it goes through your boot, steel or something doesn't protect you, you get stuck with a dirty needle. That is a problem because your body's going to develop an antibody to respond to that. That's why we use vaccines. The importance of vaccines is to help our body get used to something that might invade it so that it can protect it. Does that make sense? Okay. Now this is going to be the most difficult term you're going to look at all day. Direct contact. Well, obviously direct contact is you have direct contact. You get blood or body fluid in an open wound, an area that's abraded. You get it in your eyes, your nose, or your mouth. That is direct contact. That's pretty simple, obviously. Indirect contact is that you get it, but you don't get it directly. Here's the classic that we used to have all the time. The wood spine boards. Now with wood, what happens with wood as it gets used a lot? What can you get from wood? Splinters, thank you. Yeah. So you get a contaminated spine board. You pick it up and it's bloody or been bloody and you get a splinter. That is indirect contact. Okay? This is one of my favorite slides with infectious disease. If you understand this, you will understand so much about disease and disease transmission. Whether it's a cold, whether it's the flu, whether it's HIV, I don't care what it is. Because these factors generate everything. When I teach infectious disease classes, this is one of my slides in my intro that I use to help people understand this. First, there's got to be an organism. If there's no organism, there's no infection. if there's no, let's just use HIV. If there's no HIV and you get stuck with a contaminated needle, what is your risk of contracting HIV? 0. There's got to be an organism. If you're not exposed to tuberculosis, can you get TB? No. I mean, it's just, that's so critical to understand this. Dose of the organism. So as we look at this, there's got to be an organism. What's the dosing of the organism? How much infectious agent is there? All right, let me help point this out to you. In your Mountain Dew bottle right there, how many milliliters is in your Mountain Dew bottle right there? That's 500. That's 500 milliliters, 500 cc's. So 1 milliliter, 1/500th of that. If it was a virus such as HIV, there may be 7 virus in it. 7. If it is hepatitis B, hold on, 100,000 in that 1 cc. If it's hep C, there may be 10,000 virus in that 1 cc. Now, I just give you those numbers. I don't care that you remember those numbers. That's not the point. Here's the point. I want you to have a perspective of understanding dosing. So, if we've got HIV, a typical HIV 1 cc is going to have about 7 virus in it. When people get stuck with HIV needles for the most part, there's less than 1 cc. There's like 1/100th maybe of a cc. So the chance of contracting HIV is between slim and none. I've got a slide I'll show you in a few minutes about fire EMS people that I love because nobody in fire EMS has gotten HIV. We'll talk about that in a minute. So dosing of organism, we think about that. Then we look at how strong is that organism. We're going to talk about this a little bit more in a few minutes, but I'll give you 3 quick things. HIV, light and air, boom, dead. It's very, very fragile. Hepatitis B, it is very, 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 very strong. And we'll look at that because we've cultured it out of dialysis centers off of stainless steel. 2 weeks. Most organisms have to have a host. Remember, I was talking about a host a moment ago, us. It's got to have a host in order to live. If it doesn't have a host, it dies. HIV is a classic for that. Light air, gone. Hep B, nope. It hangs on for the long haul. Hepatitis C, not quite as strong, but generally about 6 to 8, some say 10 days. So it's not nearly as strong. And last but not least, how strong are we? What's our situation? What's your strength? Not how much can you bench press, that's not the question. What's your health status? If you are getting over the flu, then your immune system is not going to be as strong. If you've just had surgery, you tore something in your knee and you just had knee surgery, you're going to be more vulnerable and more susceptible to acquiring any type of infectious disease. Now, let me tell you something that will depress you this morning. I'm not here to depress you, but I'm going to tell you one thing that will depress you. Most people that go into the hospital without an infection, 27 to 33% of those folks come out with an infection. That's worrisome. That is worrisome. You go in with no infection, but by golly, you come out with one. MRSA being a big one that folks come out with. So this slide here, if you understand that, then you have a better understanding than probably 99% of the American public does, including many healthcare folks, about infectious disease. Just because somebody has MD behind their name doesn't mean they understand infectious disease. Through the years, I've had running battles with the ER docs about different things, especially with post-prophylactic medications, on whether you should go on medications if you had an exposure. And folks would say, well, there's no long-term problem with these. Some of these drugs we had been using less than a year, and we didn't know if in 3 years somebody was going to grow extra hand out of the top of their head. You know, I mean, you don't know until these drugs are looked at for a long period of time. So that's a critical element. If you understand that, you'll understand more of what we're going to talk about. So the million-dollar question is, how can we break the transmission cycle of disease? Wash hands. Washing hands. And you go, it can't be that easy. Yeah, it can. It really is. Washing hands. In a study that I had shared with some folks a while back, 13% of paramedics did not wash their hands after patient contacts. 13%. I was embarrassed. That was not Durham. That was nationally 13%. Has been in the last 5 years a big push in the healthcare, especially in hospitals, for people to wash their hands. That's why they've got the disinfectant outside of every room, essentially, in many of the hospitals today. And in teaching hospitals, such as Duke, UNC, where their residents, the attending comes in, and the herd follows of the senior resident, the second year resident, first year resident, the chief resident's there, and the PA student, the PA, whole world has showed up. And they all come in, and one person gets assigned to touch somebody, and they go to another one. Well, it may be 4 rooms down before they touch somebody else. They move whatever's in that room down to the next room, especially when they haven't washed their hands. Okay? So that's just something for you to be aware of. All right, let's talk specifically about HIV for a few minutes. HIV historically is the one disease that scares people the most. What I have found interesting over the years is this. Folks go, oh, you teach infectious disease. I bet you don't sleep at night. Well, actually, I don't, but it's not because of HIV. Okay? I do now. I've actually slept more in the last 3.5 years since I've been retired than I did the first 40 years that I was working. But with HIV, that's not something I worry that much about. I didn't really worry about that killing our people. I'll tell you the thing that still bothers me is our folks getting run over at a motor vehicle crash because of gawking. Fire guys, y'all too. People are not paying attention. The lights are stunning to them. They're like, they go into this suspended animation and can't drive and can't function. So it's very scary. So HIV, we all know what it means. Basically, when you have HIV, you have an immune-compromised system. Your immune system does not function very well, so you're not able to deal with things. HIV doesn't care what color, whether you got polka dots, you're white, black, pink, yellow, gray. It doesn't matter. It doesn't matter where you come from. So it involves all of us. Now, with this, HIV, there's 2 versions of that. You don't really care, but there's HIV-1 and HIV-2. But it's an agent, it is a virus, and it causes the immune system, as I told you a moment ago, to be compromised. Now, back in 1981, when this first came out, it was identified primarily in homosexual men. So immediately the thought was, well, if you're not homosexual, you can't get HIV. But if you were homosexual, you should stay away from those people because they're going to infect you if they walk into the room. For many years, EMS was under the hospital proper, Durham County Hospital Corporation. And I was on the committee, infectious disease committee at the hospital back in the late 70s or early 80s when HIV came out. And so we were doing classes for the physicians on HIV. Holy Moses. You know 5,000 times more about HIV today than those folks did. No offense. Some of them are very good friends of mine. They were, I was like, did you sleep through infectious disease? But in medical school, they don't spend that much time in infectious disease. They spend about 3 hours on dietary and nutrition. I don't know, scarce, but that's a separate issue. So, it was not until 83 that actually got the virus isolated and said, this is what it is, and this is the problem. It is in a family known as retroviruses. Now, you don't really care, but if somebody really was talking to you and said, hey, this is a retrovirus, you'll be they might be impressed if they understand anything at all. And I told you about those two types a moment ago. Window phase, let's talk about that for a moment. A window phase of any disease is from the time that there is an exposure to the time that you might change from a negative status to a positive status. Most people that have HIV, acquire HIV, from the time they were exposed to the time they convert and have HIV in their system, typically is 1 to 12 weeks. Now, it can be out as long as 2 years. 90% of people convert in the first year. But it's very prevalent in the first 12 weeks of somebody changing from a negative to a positive status. As you can see, some people have no symptoms, some will have a few symptoms, and we'll talk about the symptoms in just a second. And then others will have full-blown diagnosed HIV. Pneumocystis pneumonia. It's called P-carnine pneumonia. It is a fungus. Now, let me ask you this. If I had brought pneumocystis pneumonia in here this morning, and I walked around, I'm trying to stay where the cameras can get me here, but if I walked around and sprayed pneumocystis pneumonia in here this morning, how many of us would get pneumocystis pneumonia? Nobody. None of us would get it. Unless you have got an immunocompromised body. You would be more susceptible if you were a transplant recipient because you're on immunosuppressant drugs so that your body doesn't reject the organ. But for the rest of us, we're not going to get this. Fungus infections are difficult at best to get rid of. 6 months to a year. Typically, didn't really get rid of a fungus. And if you got a fungus inside you, it's worse. A fungus in the lungs is never a good thing to have in any shape, form, or fashion. Kaposi sarcoma is a neoplasm. It's a cancer, okay? And it's characterized by red purplish rashes on the body. You look at somebody and go, wow, that sort of looks like a bruise, but it really doesn't. That is Kaposi sarcoma. Now, in the early days, in the early 80s, when this was first diagnosed, you had to have one of these two in order to be diagnosed with AIDS, with a couple of other things, but you had to have one of those two. Kaposi sarcoma was identified at a medical conference, and what happened was this. A bunch of infectious disease guys were sitting around the table having supper, and he said, we have got something showing up on our patients that we have no idea what on earth it is. And they passed these pictures around. Some of the docs from the Mediterranean part of the world said, oh, Kaposi sarcoma, and just kept eating. The American docs almost had a stroke and like, what? They said, oh, that's Kaposi sarcoma. It had only been in Jewish men in the Mediterranean part of the world until HIV came along. So the American docs had no clue as to what this was. So that was one of the two. Now, you can have those, but you don't have to have those to be diagnosed. Problems with the mouth are situations that we deal with. GI, that's why we often, folks are often asked, okay, do you have any GI disturbance? This is typically diarrhea that's just of mass proportion, just profound diarrhea. And you can see liver disease is a big problem. The liver filters out everything, so a lot of these folks end up with liver disease as well. AIDS dementia, ADC. AIDS dementia is interesting because what they're finding is that on CT scans of people's brains who have got HIV, there is damage to parts of the brain. Now, obviously, it depends upon which part of the brain is damaged. You can have dysfunction. Frontal part, obviously, personality, changes in behavior and disposition kinds of things. Some studies show as much as 25% of these folks of HIV patients have some kind of ADC. Fever, not uncommon. Unexplained weight loss. Lymphadenopathy. That is a 75-cent medical word for swollen lymph nodes. Okay? That's all it means. Visual disturbances, folks have optic problems, and pretty much, if you've got an immune compromised system, based on what we talked about, an organism, the dosing of the organism, the strength of the organism, and how strong we are, if you have got an immune system that is compromised, what are you susceptible to? Everything. Everything. Things that we could come into contact with that probably will not even cause us to have a sniffle can kill these people who've got full-blown AIDS or full-blown HIV. Now remember, you can have HIV and not be diagnosed with AIDS. So you can have HIV and not be diagnosed with AIDS. But if anybody is diagnosed with AIDS, obviously what do they have? HIV. Good news, you can't catch it. So that's really good. In the early days, there was concerns because folks thought, well, you can catch it like the cold, the flu, like tuberculosis, but that's not something that will happen. You can see casual contacts. They've even done some studies where people shared razors and bars of soap and everything. Nobody got infected. So not really a risk for us to worry about. Non-sexual social situations. It's not going to put the person at risk. In sexual situations, the woman is more susceptible to getting HIV than the man is getting it from her. They can get it, the man can get it, but if the man is HIV infected, the woman is highly more susceptible to getting infected. I think it was about 83, 84, the concern was, I got a mosquito bite, I may have HIV. No, you may have other things. You may get malaria, you may get dengue fever, you may get a lot of things, but HIV is not going to be among the things that you get. So not to worry. Can you get it by aerosolizing it, put it in the air? No. How come? What kills it? Right there. It's outside the body. Boom, it's dead. Literally. It's probably within microseconds. It just is so fragile. And that's great that it's that fragile. So it's not something, if somebody's got HIV or even if they got full-blown AIDS and they sneeze, you're not going to get it. It's impossible. So that's not something we ever need to worry about. Fever. Fever is always an indication that something's going on. There's some kind of disease process going on in the body, some infectious process going on. 4 to 6 weeks, a lot of folks have flu-like symptoms for a long period of time, and many folks say, well, I've just got the flu. That's all it is. Remember, they convert in 1 to 12 weeks, so 4 to 6 weeks of prolonged flu-like symptoms should be a big red flag to somebody to pay attention to that physician-wise. And just generally, we just don't feel quite right. It's also a good indicator there may be something going on. And you want to add more things to it, such as swollen lymph nodes. And bear in mind that many people may have just a few days of feeling bad and then have no other symptoms whatsoever. So you have no idea that they may have no idea that they have got any problem. Continued fatigue, you can see these different things are things that we see so often. There's some rapid tests that are out there, and especially for our fire EMS folks. This is critical. We test the source patient. The reason we test the source patient is because if they do not have HIV or Hep B or Hep C, can you get it? Let's say you get stuck with a dirty needle, and we source test a patient and they're negative. Are you at risk for HIV? No. If the patient doesn't have it, they can't give it to you. They can't give you something they don't have. And that's the good news of this. This is why we focus on testing the source patient. Anytime we have a staff member infected, the source patient's blood's tested. We test for HIV, Hep B, and Hep C. There's been a big push by CDC to get OSHA to test for syphilis. And we'll talk about syphilis and sexually transmitted diseases after a while. But the rapid tests are very important because it will tell you in about 10 or 15 minutes, no HIV. If there's no HIV, you don't have to worry. It just doesn't exist. So that's very important for us to understand. The prophylactic medicine. The vast majority, over half of the people that were put on prophylactic medicine for possible exposures should never have been put on. CDC actually has a number of physician hotline that they can call and say, I've got this situation, should they go on medication, yes or no? 52% of the time, the CDC docs go, no, don't put them on anything. So that's a concern we've had through the years. All right, so what's your risk? Depends upon how sick they are. That's one part of it we talked about. If they are HIV positive, then further testing is done to find out how much virus is present in their body. And then, depending upon that, then prophylactic medications are the key for the day. Look at this slide. This is a very, very important slide. Do not. These fluids do not pose a risk. If there is no blood, no visible blood present, and any of those are there, they are not going to contaminate you. Now, if you want to play in number 3 or number 5 over there are chaplains here this morning who will be glad to talk to you. We send you downstairs and let you talk to Ralph. Okay? The smart thing is, if you're going to come in contact with some of these, putting on gloves, personal protective equipment, PPE. Everybody's got acronyms for everything, PPE, personal protective equipment. Gloves, sometimes gowns, but typically gloves, face mask to protect your eyes, your nose, and your mouth are the key things. So that's a very important slide of HIV. All right, cerebral spinal fluid. You're in a car crash and somebody has got a serious spine injury. Are we likely to see cerebral spinal fluid? Probably not. Probably not going to see it. Fluid, they got a busted up knee. What's going to be prevalent in a busted up knee? The B word, blood. All right? We're probably not going to see synovial fluid. Pericardial fluid. Somebody's got an injury, a penetrating injury to their heart. One, they may not be with us. Number two, we're not going to typically see pericardial fluid. It's going to just be blood pressure. But they're considered other potentially infectious. Amniotic fluid. Let me share a story with you. In the early days when we started doing first responders, with all the then 5 county volunteer fire departments, the policy was 3 people went into the house unless more were needed for CPR or any assistance. I got a call one afternoon, Saturday afternoons, before we had cell phones, and my hospital pager went off, and the hospital operator was screaming on the pager to call the hospital immediately, call the operator immediately. Stat. But they never screamed because they're used to paging out everybody in the hospital. Long story short, got on the phone and she said, "I've got multiple lines with people screaming and crying on the telephone for you." I was like, "Okay, give me the first one." The first one got on. I was like, English. I mean, I thought it was Farsi or something. I mean, I don't know what they were saying. And I said, "Give me the second one." Put the second one on. I said, "Use words." Bottom line was seven had been in a hotel room and the lady was pregnant. And apparently none of these young men had ever seen a woman getting ready to give birth, and they were all in the position. She pushed. They were coated, eyes, ears, nose, mouth, chest, every part of them was coated in amniotic fluid. Apparently they were fighting in the shower, fighting to get to the scene, and some were on the phone screaming. That is the largest number of exposures we ever had in Durham County at one time. Were they at risk for contracting something? Oh yeah. Oh yeah. Now fortunately this lady didn't have Hep B, Hep C, HIV, nothing. But had she had any one of those, they were spitting amniotic fluid out, as they described it to me. "Are you coming?" "No, I'll meet you at the hospital." It sounds like a disaster. I do not want to be there. So amniotic fluid is a big risk. Any fluid containing visible blood. Unable. It cannot reproduce itself. That's good news. So what are your risks? Any kind of deep injury puts you more at risk. So avoiding these kinds of things. An ounce of prevention is worth a pound of cure. Visible blood. If you see visible blood, then you should use personal protective equipment. We already talked about that a minute ago. Any device is placed into a vein or artery. Somebody who does IV drugs. We put the IV catheter in somebody. Today we have safety needles. When they pull it out, they push a button, and the needle withdraws to make everybody safe. And if a patient is dying with AIDS, then we suspect they would have a higher count of virus than normal people would. Occupational exposure. Fire EMS people. These were through 2013. They haven't had any other numbers since then. Look how many were fire EMS. There have been many articles that have been published in emergency journals over the last few years, especially 5 or 6 years ago. And many of these folks said, hey, I'm a paramedic and I got infected at work. All of those were investigated. And CDC investigated those things. And what they found was this. CDC and OSHA, actually. None of those folks had reported an occupational exposure. So there's 2 take-homes, and especially for the fire folks. If you get exposed, report it. Report it immediately. Not 2 days later, not 2 weeks later, not even 2 hours later. Report it because we need the source patient's blood tested. So report it immediately. If you don't report it, did it happen? Nope. And especially for workman's comp, it didn't happen. So the importance of this slide right here, no EMS fire people were infected. The 49 folks that were, most of which were surgeons and surgical nurses. And most of those involved scalpels. Okay, talking to you about HIV a moment ago, just to tell you there are some medications that are being used to assist with folks who have got it. The bottom line is you've got to be on these meds 48 weeks. There's a whole pile of them out there, a bunch of new ones, but it takes about 48 weeks to get rid of or suppress the HIV enough so that you test that you're not HIV positive and you reduce your risk. So that's pretty much HIV that I was going to talk to you about. Hepatitis B. Hep B. In many places in the world, this is the leading cause of death. Hep B in the United States, we don't really worry very much about it anymore, not to the extent we did back in the 70s and 80s. But it's a disease of the liver, and itis on the end of anything is inflammation or infection. So if you've got tendinitis, you got an infection or inflammation of your tendon. So itis on the end of anything medically, if you know that, you can figure out a whole lot of things. A couple of things. It's obviously blood. That's what we're talking about primarily this morning. I told you a moment ago it's liver. It can occur for a number of reasons. A lot of folks that have it get it from various and sundry infections. Some folks get it from alcoholism. That can be one of the causes of this. Exposure to drugs, chemicals. A lot of folks have got liver disease that were in Vietnam, were exposed to Agent Orange. They've got liver problems related to that. The interesting thing with hepatitis B is that only about 5 to 10% of people who have it are actually carriers, meaning they would be communicable. They could transmit it via blood. So the majority of people who have it are not really much of a risk. The other interesting part of Hep B is this. More than half the people that have it have no idea they have the disease. They've had minimal or no symptoms, and there's no realization they've even got it. It's one of two, this and Hep C, can live outside the body. I told you earlier it can live 14 days in dialysis centers on stainless steel. We'll throw a bunch of symptoms up here. Those are some of the symptoms. Now you look at those and you think, so, flu-like symptoms. In teaching infectious disease classes, one of the things I tell the students, you can always get one question right on an exam if you are asked, what is a symptom of, a sign or symptom of an infection? If you say flu-like, you're always going to get one question right. So you should never get a 0, although some came close. You shouldn't get a 0. Now, look at this one, light-colored stools. What do you think? So why are you telling me about light-colored stools? I tell you about that because we typically ask people who have gastrointestinal bleeding what color stools they have. Dark, tarry stools, black tarry stools are an indicator to us that somebody may have a GI bleed. If they're vomiting coffee ground stains, then they have an upper GI bleed. And when we think about this, we think about GI bleedings because gastrointestinal bleedings are a big issue EMS folks and hospitals deal with. Light-colored stools would be indicative that somebody may have Hep B. Over here, dark urine. What are other reasons you can have dark urine besides having hepatitis B? Dehydration. Yeah. Homeland Security at many of their facilities, especially the ones out in the desert, have got signs in the bathroom. If you're literally got signs that say, if your urine is dark, you're not hydrated well enough. To try to keep everybody hydrated because having Playas, New Mexico, one of the training sites, it is hotter than blue blazes out there. And you watch the blimps drive, float by and watching everybody, coming across the border, and you just holler and everybody runs. So, those are some of the symptoms. Remember I talked to you about a period with HIV between 1 and 12 weeks, a window phase, or incubation period. Look at it for Hep B, 45 to 200 days. So you could be exposed today and it'd be 200 days before you actually became symptomatic. It's both obviously in the liver. We're primarily talking about blood. It is sexually transmitted. That's important. Moms giving it to babies. That is an important concept to understand, both with HIV, Hep B, and Hep C. There is a vaccine. It's been given since 1982. In the early days, it was a live virus. It's no longer a live virus that you get. It is effective for life. This is one of the controversies in the infectious disease circle. Many people believe, are told, you should get a booster every 5 years or 10 years. Now, the people that were promoting that were the pharmaceutical companies, going, you need a vaccine every 5 years in order to stay protected. No, you do not. You do not need a booster shot. There are many people in the infectious disease world who tell you that it's not. I've spent a gazillion hours studying and sitting under the gurus of infectious disease. You don't need that. Those are some of the vaccines that are used. Let me just share one thing about B before I talk to you about C. Healthcare workers are less likely to have Hep B than the general population. Folks go, what? Are you kidding? Well, given the fact we're exposed to so much blood and body fluid, you say, well, we ought to be more at risk. We use personal protective equipment. So if you look at percentages of people who have acquired Hep B, healthcare are lower than Joe Citizen, Sue Citizen out in the street. Just FYI. All right, let's talk. I told you a minute ago, it can live about 16 hours. Some people say it can live, a week or so, but we know definitely 16 hours. These are some of the ways that it's transmitted. Straw is used for drugs, snorting drugs, especially tattooing. Now, let me share something with you. I am not here to poo-poo on your tattoos, if you have tattoos. I'm not here to poo-poo on them, okay? Here's the reality. A couple things we do know. Tattoos have been the causative factor for a lot of infectious disease because they have reused needles or they have reused the ink wells, and so while they may use a clean needle on you, that ink well, they have stuck a needle in that ink well X number of times. So that's the problem with some of that. Tattoos are also considered open wounds. Now, that only has been prominent in the last 2 years. Now, when you stop and think about it, you go, my golly, that should have been obvious 10 years ago. But tattoos are considered open wounds. So if you have a new tattoo, you should cover that minimally of 1 week. And most of the folks that I've talked with who are, I consider gurus in infectious disease, are saying to be on the safe side, you should keep it covered for 1 month. And don't let any blood, body fluids get into it. And even to the extent, if it's a new tattoo, you shouldn't get in a river or a lake or pond or anything like that. Some are even saying, don't even get in the Atlantic Ocean. Because all the stuff that's been stirred up with the storms and the hurricanes the last few years, there's more contaminant in the ocean than there's ever been. So from a tattoo perspective, just make sure that you don't put yourself at risk from that perspective. There's some rapid tests. I told you a moment ago, the two with HIV, we want rapid testing of the source patient. We're going to do rapid testing for hepatitis C. We don't worry about rapid testing. There's no rapid test for Hep B. The risk of getting Hep B is so minimal. Tests are still performed, but we have not had, unless we've had in the last couple of years, we have not had anybody, any source patient show up with Hep B that didn't either have HIV or Hep C. So not a big factor for us to be aware of. There's some new drugs out there that will cure hepatitis C. And hepatitis C, ladies and gentlemen, is the leading cause of liver transplants in the United States. Many of these drugs are in anywhere from the $50,000 to $250,000 range. But folks are jumping on this, insurance companies are jumping on this, because that is a token amount of money to spend. When you start looking at liver transplants and long-term immunosuppressants, spending $50,000 or even $250,000 is nothing compared to the millions of dollars of getting a liver transplant and staying on medicines the rest of your life to keep your immune system suppressed. This is just one of the newer ones. Epiclesa is a cheaper one of the drugs, but it's a very good drug as well. All right, let's talk about tuberculosis. We have been talking about what? The V, viruses. Now we're going to talk about bacteria for a moment. TB, Mycobacterium tuberculosis. It can go through the air and it can go through blood. And generally, it can be in the body, in the organs, but we're primarily going to talk about if it's in the lungs or throat. Now, tuberculosis had basically been eradicated in the late 60s, early 70s. Before that, if you had TB, you were put in a special hospital with everybody else with tuberculosis. Now, here is why TB was pretty much at a very, very low level and then just took a rise in the early 80s. Once upon a time, hospitals did not have private rooms for the most part. Yeah, there were some. They had a few semi-private. Most of the hospitals had wards. A ward would be a room about where y'all are sitting back this way, and then would be separated by curtains. And they could have 8 or 10 patients in this area. And what happened was, as HIV started emerging, these folks had what kind of compromised system? Immune. So the HIV patients were immunocompromised. They put patients with tuberculosis on those wards. Well, they sneezed and coughed. I don't know if any of them sang, but spit, did anything they were doing. And who got sick? The HIV patients. And so all of a sudden, the HIV patients not only have HIV, but they also now have tuberculosis. And it took a few years for somebody to figure out, perhaps we should not put patients who have got immunocompromised immune systems in an area where somebody has got an airborne bacteria. Now, we look at it today and go, were they stupid or what? Well, yeah, they were. I mean, that's really all you can say. It was stupid. So TB that was basically eradicated all of a sudden had this massive resurgence, and everybody was in a frenzy that they were going to get tuberculosis. So that's why TB numbers went off the proverbial chart. Now, tuberculosis is still a leading, one of the leading cause of deaths in many countries today. So that's a concern. Once again, as with HIV, it hits light and air, and generally it dies. It lights dark, dusty, closed-in spaces like heating, air conditioning, kinds of places like that. Much like Legionnaire's disease. So, respiratory components. Blood tests are much more effective today than the skin test. I am not a fan of the skin test. Right before I retired, we had all our people, had blood drawn on all our people. And I was working with the health department with this, and they're going, do you know that that's going to cost more money to have the blood test? I'm like, no, it's not. And the reason it's not is because with the TB test, the time test, they've got to come back in 48 hours and have it read. And I got people everywhere. I got to pay them to come back. No, the blood test is going to turn out, short term, is going to save a boatload of money and make my staff a lot happier and make me happier just to do it. So the blood tests are much, much more effective. You don't have to worry about not washing that area. You don't have to worry about 24 hours somebody calling you going, I have TB. If you ought to see my arm or send a picture. Look at has it been 48 hours? Oh, no, sir. Then don't worry. If it looks like that tomorrow, call me. And they never got another call. So the blood tests are much better. Sexually transmitted diseases, the big three that I want to talk to you about. Now, you may think, okay, so why are you talking to me about sexually transmitted diseases? Several reasons. Number one, because you need to understand the problem of sexually transmitted diseases. Number two, many people who have syphilis have HIV, Hep B, or Hep C. For a number of years, OSHA, CDC has been asking OSHA, make this part of the mandatory test for exposure. Because of the number of folks who have syphilis have got one of the other big three that we are concerned about. U.S. numbers, 115,000 syphilis cases. You may think, well, that's not many. Those are brand new cases. That's not including the gazillion that have already got syphilis. And many of these folks take the medicine, some of them don't take the medicine, some of them have active syphilis. Risk groups. You can see down to here, those have been consistent for probably the last 15, 20 years. In the last few years, senior communities have had significant numbers of syphilis. A quick illustration. I was helping a nurse practitioner and health department here in North Carolina, and they had about a dozen of the residents that came down with syphilis. 12 ladies, 12 women, and one man. And when we sat down and talked with them, and sat down with the man and said, sir, we tested lots of people, and you're the only one that's tested positive for syphilis. And these other 12 ladies, do you know all these ladies? He said, yeah, they're my girls. I'm like, okay. I said, we believe you are the primary factor in the syphilis. He just looked at me and he said, son, can I ask you a question? I said, yes, sir. He said, have any of them complained? I said, excuse me? He said, have any of them complained? I just sat there. We went out of the room and looked at each other, the nurse practitioner and I were like, did we just really hear? I'm having a dream. Interesting thing about that whole conversation with him was one of his other comments when we went back and talked with him. He said, I thank God for the little blue pill. He was very proud. And so we did some counseling, which was probably as useful as me trying to go outside and blow the building across the street 5 feet back. But anyway, it is a major problem in the senior communities, and that is not an isolated story. The senior communities are one of the fastest growing areas of syphilis today. Gonorrhea, for folks who have been in the military, gonorrhea was a big problem with military folks. And we used to have folks come in to the emergency room and see us and would have gonorrhea, and they would get 1 million units of penicillin in each butt cheek. It is very thick. It is very painful to give people this. And if they were acting very kind, we would kind of warm it up. But if they were really jerks, don't be ugly to us. But here's why I tell you that today. We were kind to people. It's increased 580,000 cases. As of this week, that's the highest number that's ever been reported to CDC since 1991. I knew it had been a long time, but this week when I was doing some updates on this for y'all, I found this. It is off the chart. So gonorrhea is a big problem that we're starting to see. Chlamydia. Let me tell you a funny thing about chlamydia. I was doing an infectious presentation similar to this, and one of the gentlemen raised his hand and said, why are you talking to us? It was all men. He said, why are you talking to us about chlamydia? Men can't get chlamydia. I was like, pardon me? He said, men don't get chlamydia. Son, I'm not sure what rock you're living under, but yes, men get chlamydia also. Well, I've never heard of it. Well, I'm going to burst your bubble and tell you men get chlamydia. So men can have chlamydia as well. Once again, it's gone up. Not quite as great a percentage, but it's still gone up. Over 1.7 million cases. This is the most that's ever been reported to CDC. So, syphilis, gonorrhea, and chlamydia are three big concerns. Now, from an infectious disease point of view, most of these you should not come into contact with in an occupational exposure. But you still want to protect yourself from blood and body fluids from these folks. There is so much more sexual promiscuity with every age, and somebody is moving it from person to person, and they move it from somebody else to somebody else, which is why we see a 3% increase to more than 1.7 million cases. I mean, that's crazy. In numbers that we haven't seen since 1991. Just an interesting thing with syphilis. Since 2000, CDC's had a goal of trying to reduce syphilis to zero, to eliminate syphilis. And by 2005, it was not eliminated. Actually, if you were looking at it on the chart, it was continuing to go up. And so they said, by 2010, we want to eliminate it. And 2010 got here, and it was still on an upswing. They said, well, let's aim for 2015. And I said in classes, I would be tickled to death if we could eliminate syphilis. I think a snowball has a better chance in Hades of surviving than we do that. 2015, the numbers were still like this. And so you can guess, what did they target? 2020. Well, folks, we are arriving at 2020. And guess what? It's still present. In fact, not only is it present, it's climbing. So the bad news is, syphilis isn't going away. These others aren't going away anytime soon. Now, here's one other problem with all of that is drug resistance. This is a multi-day presentation on drug resistance. We have overprescribed antibiotics. And my staff for the years would know, oh Lord, she's getting ready to lecture on drug resistant. We'll be here to Christmas. It is a big problem. So just FYI. Measles. So you may think, okay, why are you talking to us about measles? Well, I'm talking to you about measles because right now we are seeing measles becoming rampant across the United States. 31 cities have had lots of problems. 31 states, I'm sorry, not cities, 31 states. But we, North Carolina so far, thankfully, have not been involved in that. It's a concern. So keep your eyes out for that. You can just Google measles 2020 and read information on that. Now, a couple things as I start winding down. What are some concerns of other infectious diseases in the world? One I didn't put on here, but I want to talk to you about for just a second, is the flu. Yesterday, there was a report that a 15-year-old young person died up in the mountains with flu. There's strains of A and strains of B. B is more prevalent this year than we have seen in years past, and B seems to be hitting the young people particularly hard. So that's a concern that we've got. So flu is an issue. Ebola. You may think, well, I haven't heard anything on Ebola, so Ebola's gone away. No, it has not. We're still dealing with Ebola. I was the Ebola guru during the Ebola crisis here. I talked to all kinds of people who call 911 and say, I think I may have Ebola. They say, hold on, they get information, call to me, so I would talk to these folks. Folks would think, well, I was in Dallas, so I've been exposed to Ebola. Did you come in contact with the patient? No. Did you go to the hospital? No. Just because you were in Dallas, you and millions others were not infected or exposed, not infected, exposed. MRSA continues to be a problem. I told you a minute ago, a lot of people who leave the hospital leave with a gift, an infectious disease gift, MRSA, one of the big ones. Dengue fever is a problem. Dengue fever is an issue we haven't really thought much about for years, but dengue fever is starting to come back around. We're starting to see a lot of it, along with malaria. And malaria in a lot of countries is a major issue as well, not so much here. And then, as I told you a moment ago, drug-resistant organisms, the overuse and the misuse of antibiotics. If you are on an antibiotic, you should take the entire regimen of your antibiotic. It's critical, because if you don't, you suppress the bacteria, and then when it comes back, you're going to need more antibiotics, a different one often, and a much stronger. So there's lots of problems associated with that. All right, we're going to stop with that. Thank you for letting me be with you and share this information. I'm going to turn it back over to Ralph. Thanks, Ralph.
Tell them how much you appreciate it.